Okay, good morning. My presentation is on associations between hypothyroid hormone therapy and attention deficit hyperactive disorder outcomes. Hi, my name's Alyssa Winter Joe. Below it is my English translation. I currently live in Goodyear, Arizona, but I am originally from McCracken Mesa, Utah. I am currently a student in the Bachelor's of Science program for biology. And last spring, I completed my social behavior science degree. I graduated with Arizona Space Grants honors, and I am also a student with ADHD and have suffered multiple TBIs. My objective of my research is to look at the significant relationships between patients who have hypothyroidism and have developed ADHD and their course of treatments. The key points I did look at was the thyroid controls the body's functions, and ADHD is a chemical imbalance. Both have high incidence. When it comes to thyroid, there are 3 different types. Hyperthyroidism has low TSH and has a high T4. Primary hypothyroidism has a high TSH and a low T4. There's also a secondary hypothyroidism, which has both low TSH and T4s. And the thyroid is a negative feedback. As mentioned before, primary hyperthyroidism is caused by the disease in the thyroid. It is an autoimmune disease and it has an increase of TSH. Secondary hypothyroidism is hypothalamus produced low TRH and or the pituitary produces low TSH. Subclinical hypothyroidism might be targeted due to the fact that most females do not know they have the disease. It's often commonly mistaken with ADHD because they do have the same symptoms. Listed below are the 3 types: autoimmune disease, hematoma, and iodine insufficiency. When it comes to ADHD, there are markers for this, which is inattention deficit, hyperactive, and impulsivity. Is a disorder marked by an ongoing patterns of the listed characteristics, which can interfere with functioning and development. Commonly diagnosed in childhood, but often misdiagnosed. The symptoms must show before the age of 10 or 11. CDC has reported that 9.4% of children in the United States between the age of 2 to 17 have been diagnosed with ADHD. My connection and hypothesis with my research is brain chemical alterations by thyroid disorders and can also impact ADHD symptoms. If the thyroid is not sending the proper cell signals, the body won't function correctly, and the brain will receive mixed signals, which could interfere with symptoms already existing in ADHD. The data source that I use is the Symphony Medical Claims dataset as listed below. The data collected was from January 2010 to June 2018. The data set our study required everyone to be diagnosed with hypothyroidism. From here, our enrollment criteria was that patients with active records 6 months before the diagnosis of hypothyroidism and at least 3 years after. From there, the study outcome used the 6 months before the index state of the hypothyroidism to assure the comorbidities. There was a 10-year washout period before the index date, starting at the. We then surveyed records for patients treated with medication or that were not treated with medications that ended up developing ADHD. The inclusions and exclusions of my research, we excluded schizophrenia, traumatic brain injuries, autism, and anyone over the age of 35, and patients who have been diagnosed with ADHD before hypothyroidism. What I included were people between the age range of 0 to 35. Their enrollment criteria is at least 6 months before and at least 3 years after diagnosis of hypothyroidism. Within our drug therapy, we were able to categorize them with synthetic animal T3s, synthetic T4s, and synthetic T3s, and TSH. Listed below are the codes we used. When it came to our methods, we first began looking at a bucket with hypothyroidism. With that, we started to exclude patients who either had the TBI, schizophrenia, autism over the age of 35, and that gave us 184,000. That was pre-enrollment. After looking at the records and doing the enrollment criteria, we got 35,000. And from there, we were able to split them up based off of records that showed they were on any of the medications that were listed. 20,000 patients were being treated for hypothyroidism, and out of those patients, we had 1,111 patients who ended up developing ADHD after that first year, and 27,000 patients did not develop ADHD after. On the other side, we had 10,000 patients who were not on any medications for hypothyroidism, and 797 patients ended up being diagnosed with ADHD, and the 10,000 other patients were not diagnosed with ADHD after the first year. My patient demographics, we split up based off of the non-treatment and treatment group of hypothyroidism. We had more females in both groups, and the large population was in the 30 to 34 range. The minimum for the hypothyroid medication was 2 to 4, and on the non-hypothyroid medication was from 0 to 2 to 4. These are the codes we did use for hypothyroidism, And as it went into categories with and without drugs. As you can see, the non-specific acquired hyperthyroidism is more of autoimmune disease. Um, okay. This is our medication breakdown by type. As mentioned, there is the animal T3 synthetic and the synthetic T3. They are separated based off of what type of hypothyroidism that they do have, and is listed on the side how many. And a continuance of this is the T4 drugs and the TSH. My results, the relative risk was 0.5226 with a 95% CI of 0.4785 to 0.5709, suggested of a protective effect. Um, the the NNT is 20. 1 out of 28 patients are expected to have a positive result. The conclusion suggests the conclusion of my data suggests that the patients who have hypothyroidism and are taking the proper medication, there is a decreased risk for developing ADHD. Future analysis will include propensity score matching population, and we'll look into the effect of individual drugs, types of hypothyroidism, and comorbidities of ADHD incidence.